Hello and welcome to the Clinical Care Options Oncology podcast. I'm your host, Nicole Rochino. Today's episode features expert discussion on the diagnosis and typical presenting symptoms of gastroenteropancreatic neuroendocrine tumors, or GEP-NETs, as well as a discussion of recent key phase 3 studies, including NETTER-2 and CABINET. Dr. Thor R. Halfdanarson from the Mayo Clinic Comprehensive Cancer Center in Minnesota and Dr. Jonathan Strosberg from the Moffitt Cancer Center and Research Institute in Florida also provide recommendations for treatment and monitoring, and some notable clinical pearls regarding GEP-NET therapies are also highlighted. This episode is part of a larger educational program titled Clinical Focus: Expert Insights on New Advances in the Treatment of GEP-NETs. For more information on Drs. Halfdanarson and Strosberg, along with a link to the larger education program, please visit the show notes for this episode. Now let's get started and hear what the experts have to say about this important topic.
Hello, my name is Jonathan Strosberg. I'm a medical oncologist at the Moffitt Cancer Center in Tampa, Florida, and I'm going to be talking today with Thor Halfdanarson from Mayo Clinic about advanced neuroendocrine tumors.
Hello, and my name is Thor Halfdanarson. I'm a medical oncologist at the Mayo Clinic in Rochester, Minnesota, and I will be talking to my colleague, Dr. Strosberg, about the same.
Thor, can you tell me a little bit about how you diagnose GEP-NETs? What are the typical presenting symptoms in the diagnostic workup?
Absolutely. So I think I find it helpful sometimes to break this down into the presentations of localized versus advanced neuroendocrine tumors. So if you just focus on the localized, this is sort of the gastroenteropancreatic neuroendocrine tumors. So localized pancreatic neuroendocrine tumors can, and often are asymptomatic, and they are increasingly found incidentally on imaging studies done for other reasons. So someone goes in for a CT for a kidney stone or whatever, and there's a lesion on the pancreas, and there are no symptoms whatsoever. But a relatively small minority of them, maybe 20, 30% at most, probably less than that, are functional pancreatic neuroendocrine tumors that produce hormones that may result in symptoms. The most common of them would be gastrinomas productive of gastrin, causing the Zollinger-Ellison syndrome, with severe heartburn and reflux and diarrhea, and in extreme cases, bowel perforation, typically stomach or duodenal perforation. And then the other one that's fairly common is the insulinoma, which results in these recurrent episodes of hypoglycemia. And so there are definitely other less common neuroendocrine tumors of the pancreas causing functional syndromes, but these would be the most commonly seen ones. So for the small bowel neuroendocrine tumors, which are numerically more common than pancreatic neuroendocrine tumors, symptoms from localized disease are not always there, and a lot of times would be something like a bowel obstruction or recurrent bouts of abdominal pain, sometimes over many years, where there is this unexplained abdominal pain, sometimes associated with nausea and vomiting, which we think is these intermittent partial small bowel obstructions, and ultimately this can lead to imaging, and we have the diagnosis. Much less commonly, but occasionally seen, would be unexplained anemia from blood loss into the GI tract from a small bowel neuroendocrine tumor that's slowly or intermittently oozing blood. So that's for the local tumors. So for the more advanced metastatic neuroendocrine tumors, well, for the pancreatic neuroendocrine tumors, it can be just symptoms from tumor bulk and symptoms from hormone production, or both. And for the small bowel ones, often the carcinoid syndrome. So these are tumors that produce a whole host of different bioactive chemicals, the best known being serotonin, that causes the diarrhea of the carcinoid syndrome. There are other compounds as well that cause these spells of vasodilation that are thought to cause the flushing of the carcinoid syndrome, which often, but not always, coexists with diarrhea. The presentation is really a mixed bag of symptoms and physical findings, but in terms of the diagnosis, we obviously need a biopsy or a tissue sample of some sort. We need to confirm that this is what we're dealing with using specific immunochemical stains for the tumor, so the neuroendocrine tumors have a certain appearance and they stain in a certain way with certain immunochemical stains. And then in terms of diagnosing or evaluating the extent of the tumor, we need proper imaging. So the go-to imaging would be contrast-enhanced MRI or CT. Very important for CT scans, dual-phase contrast, both arterial and venous contrast. And then if we've confirmed with a biopsy a neuroendocrine tumor, then some sort of somatostatin receptor imaging, like gallium-68 dotatate PET-CT or copper-64 dotatate PET-CT, which we're now increasingly calling somatostatin receptor PET-CT. So that would sort of be, in a nutshell, would be the way we diagnose, and that's how they present.
Sounds great. That was a really nice exposition, but very significant range of diagnoses. As a medical oncologist, I think we tend to see more advanced symptomatic patients, but certainly other specialists like gastroenterologists and surgeons will often see small localized incidental tumors. And it's a mix of tumor-related symptoms and hormonal symptoms or incidental findings. So the next issue is the latest data or trials that have come out recently in the GEP-NET space. And I would say that there have been a few key phase 3 studies that have come up in the last year. The first chronologically is NETTER-2, which was first presented at GI ASCO at the beginning of the year. This was a successor to the NETTER-1 study, which compared lutetium dotatate versus high-dose octreotide for small bowel, mid-gut neuroendocrine tumors. NETTER-2 looked at a more diverse group of gastroenteropancreatic neuroendocrine tumors, so basically originating throughout the GI tract and pancreas, but in general higher grade. So it was higher grade 2 and grade 3 tumors, meaning Ki-67 over 10% until 55%. So 10 to 20% is higher grade 2, 20 to 55% would be grade 3. And it was rather than a second line and beyond study, it was really a first line study. So patients who were really newly diagnosed with advanced metastatic disease, and they were randomized again to lutetium dotatate versus high-dose octreotide as a control. The primary endpoint was progression-free survival, PFS, as is the case for almost all phase 3 neuroendocrine tumor trials. And it was a highly positive study for that endpoint. The median PFS improved very significantly with lutetium dotatate versus high-dose octreotide. The response rate with lutetium dotatate was also quite high. It was, I believe, 44% versus, I think, about 8% with high-dose octreotide. So clearly a positive trial, and opens up it as a treatment option for newly diagnosed patients with relatively aggressive GEP-NETs. Now, my interpretation of this study is that lutetium dotatate is an option. It may not be the only option. There are other treatments that one can consider in the space. For example, for pancreatic NETs, particularly cytotoxic chemotherapy can work quite well. Regimens like capecitabine temozolomide, even FOLFOX can be active in advanced pancreatic NETs. And sometimes if we're talking about the lower end of that Ki-67 range, more in the let's say 10 to 15% range, and not too many symptoms or not too high a tumor burden, you can even still consider starting out with a somatostatin analog and then reserving more aggressive therapies such as lutetium dotatate for progression. I'm curious, Thor, how you interpret NETTER-2.
No, I think I would interpret it in the same way. So if we look at the primary endpoint of the trial, the progression-free survival, in this particular population of patients with a bit more aggressive but still well-differentiated neuroendocrine tumors, there was definitely a much better progression-free survival in those receiving PRRT. But what remains to be seen, and probably won't be seen until we've seen some longer-term data, is the effect on overall survival. And other things I would be interested in would be quality of life, control of symptoms, things of that nature. I do agree with you that this is not the only first-line therapy for this cohort of patients. You have to have that discussion with your patient. And maybe, John, I'll ask you about it, because this trial did include patients with both pancreatic and small bowel neuroendocrine tumors. So how would approach this if this was a patient with a pancreatic neuroendocrine tumor based on your work with chemotherapy such as capecitabine and temozolomide versus maybe a small bowel neuroendocrine tumor? Would you look at these two different patient groups differently?
Good point. So the plurality of patients on NETTER-2 were actually pancreatic primary. Small bowel is numerically overall more common, but most small bowel neuroendocrine tumors are fairly low grade. We don't see a lot of high grade small bowel NETs, and sometimes they're in the so higher grade 2 range. But there's definitely more options for pancreatic NETs, and chemotherapy almost certainly works better for pancreatic NETs than small bowel NETs. It's very hard to compare efficacy of lutetium dotatate versus capecitabine temozolomide. I should mention there is a cooperative group trial run by your colleague at Mayo, Dr. Hobday, which is actually comparing lutetium dotatate to capecitabine temozolomide in metastatic progressive pancreatic NETs. But if there's an urgency to start treatment quickly because of symptoms or high tumor burden, then chemotherapy can generally be started more quickly.
So I've been impressed, at least with some of the patients with functional pancreatic neuroendocrine tumors I have treated with lutetium dotatate. Sometimes I've seen really good responses in terms of controlling the hypoglycemia of insulinomas and some of the other functional symptoms. What's been your take on patients with symptomatic small bowel NETs with carcinoid syndrome? And would that, let's say if you had someone who would fit the NET2 patient population, would you be more inclined to go with radioligand therapy if there was a lot of symptoms or not necessarily?
Well, if they meet NET2 criteria and if they have Ki-67 above 10%, high tumor burden and high symptom burden, I think it would be reasonable to start first-line lutetium dotatate along with the somatostatin analog. I mean, typically you'll start the somatostatin analog first just because we can start it the same day that the patient first shows up in clinic if they're newly diagnosed. But I would probably arrange for them to start lutetium dotatate sometime in the near future. Have them see nuclear medicine. I should point out, for many patients with small bowel NETs, one of the main alternatives to lutetium dotatate is liver embolization. Many patients have liver-dominant disease, and liver embolization is not only effective at controlling disease in the liver, but also at rapidly palliating hormonal symptoms related to liver metastases. So that would be another consideration, but obviously not one where we have high levels of data at all.
I'm glad you brought up the regional therapy, because it feels like sometimes with more and more systemic agents coming onto the scene that people sometimes forget that embolization, even the plain embolization of liver metastases, can be extremely effective controlling functional syndromes of both carcinoid syndrome and functional pancreatic neuroendocrine tumors.
Now, the next study that's made a lot of waves, the next phase 3 study that was just published last month in the New England Journal of Medicine, was the GEP-NET study, which compared cabozantinib to placebo in patients with neuroendocrine tumors, both pancreatic and non-pancreatic. So it was a 2-cohort study, a smaller cohort of advanced progressive pancreatic NETs, and then a larger cohort of gastrointestinal as well as thoracic NETs, so thoracic being lung and thymic. What were your impressions of that study?
Yeah, so my impressions of that study is that we have a new agent, cabozantinib, which is an oral or multi-kinase inhibitor. And really what struck me with that study were two things. Well, number one is that the agent clearly has activity in patients who have previously received systemic therapy, including a population that was largely treated with PRRT or radioligand therapy with lutetium dotatate before. And so in the small bowel, or that is the non-pancreatic cohort, the improvement in progression-free survival was not maybe as large as I would have liked to see, but in patients with pancreatic neuroendocrine tumors, there was actually a substantial difference in the PFS, which I think is both statistically and clinically relevant. But for the small bowel group, I'd say this is important because this is a group that hasn't really had a whole lot of treatment options before. Also worth noting is that although cabozantinib is a safe drug to give and overall fairly well tolerated, the dose adjustments or dose reductions were actually fairly common. I believe 60 to 70% of patients needed to have their doses adjusted at least by one dose level. But that said, most patients are able to stay on the drug. So I think it's a new and important addition to the list of active systemic therapies for both pancreatic and small bowel NETs. So curious to hear about your take on that, John, now that what we're seeing in the pancreatic NETs, the difference in the PFS between cabo cabozantinib and placebo was actually fairly striking, and as I recall, fairly similar to the difference that we saw with sunitinib and the placebo in a study done a decade earlier. So just curious about your take about the kinase inhibitors for pancreatic NETs in particular.
Right. So cabozantinib targets primarily the VEGF receptor. It also targets c-MET. As we discussed, there were two cohorts. The pancreatic NET had a better hazard ratio than the non-pancreatic NET cohort. So, not a dramatic difference between these different targeted drugs as far as hazard ratio for progression. Also not dramatic differences as far as response rate. But in general, my impression is that cabozantinib is slightly more effective if we're allowed to do cross-trial comparisons, which of course we generally shouldn't, but we do anyway. So that's my impression. I think it's similar to sunitinib and in terms of both side effects and efficacy, but probably a little bit more effective, and also fairly similar to everolimus, but maybe slightly more effective. As you pointed out, the starting dose of 60 milligrams can be quite difficult for patients to tolerate, especially frail or elderly, and I suspect many people will be starting at lower doses. The hazard ratio for the non-pancreatic NET cohort, not just small bowel, but generally gastrointestinal, lung, thoracic, was still quite good. It was a relatively aggressive population. The median PFS in the placebo arm was a little bit less than 4 months, and I think it was close to a year with cabozantinib. So overall, I think a very reasonable option, and a lot of people will be asking how we integrate cabozantinib into the current treatment algorithm. We have lots of drugs, especially for pancreatic NETs, that haven't really been compared to each other. They've been compared to placebo or to other comparatives such as high-dose octreotide, but it's very hard to know how to sequence these treatments without comparative trials. And even if we do have comparative trials, we're primarily comparing PFS, not overall survival. We just don't have the statistical power in patient population to do overall survival comparisons, which makes the whole situation of treatment sequencing very complicated. But what are your thoughts on where it fits in and how it compares to these other drugs we've been talking about?
Yeah, so great question. So I think right now, I think it's a very sensible choice for small bowel NET patients after they've had upfront somatostatin analog therapy and perhaps PRRT with lutetium dotatate. And we're now talking about sort of general population of patients with small bowel NETs that may not have or have fit within the criteria of the NETTER-2 trial. And the question for me in the small bowel NETs is really after PRRT, are we going to go with cabozantinib or with everolimus? And I will point out that we still don't have a whole lot of information on how cabozantinib affects the symptoms of patients with carcinoid syndrome. I do not expect there will be a whole lot of activity there, and we're still waiting to see the long-term quality of life data from cabozantinib, which might actually help. But I think probably more important than the exact sequencing in these patients, whether it should be cabozantinib or everolimus, is probably the presence of comorbidities. So let's say you have a patient with poorly controlled diabetes, you may not be too keen on treating with everolimus because of worsened glycemic control. On the other hand, if you have someone with refractory, poorly controlled hypertension, a kinase inhibitor like cabozantinib may be challenging. So I think we have to take that into account as well as the fact that everolimus has not really been statistically shown to improve outcomes in patients with functional small bowel neurotumors with carcinoid syndrome. So as for the pancreatic NETs, that's where it gets, in my opinion, much more difficult, because now we have more options. So you have the upfront somatostatin analogs and even PRRT for those with a higher grade. And then we have capecitabine temozolomide, which has been shown to be very effective in retrospective and prospective studies, but no head-to-head comparison of PRRT and CAPE-TEM in that population. So I think about it this way. So upfront somatostatin analogs and now possibly PRRT or CAPE-TEM, depending on the situation and symptoms. And then you have those three options. And beyond that, we have the cabozantinib and the everolimus. And again, I think you have to take into the account the patients' preferences, comorbidities, and things like that. So I am struggling with where to fit the cabozantinib in. I realize it's a useful new agent for us, but where it ultimately fits in remains to be seen.
Right. So we're encountering some interesting situations, I think, because if we look at the hierarchy of efficacy, both in terms of PFS and response rate in patients who progress on somatostatin analogs, which are typically the first-line treatment because they're so well tolerated and so low risk. But let's say patients progress on somatostatin analog. I think it's clear that lutetium dotatate and capecitabine temozolomide have the longest PFS and the highest response rates compared to the targeted drugs, cabozantinib, as well as sunitinib and everolimus. But I think we're increasingly encountering situations where tumors of the pancreas can transform into higher grade neuroendocrine tumors over time. And then the question is, do these cytotoxic treatments contribute to that disease transformation? We do have some data that temozolomide-based therapy can lead to a sort of a hypermutated phenotype that's also associated with high-grade transformation. We may be seeing similar things sometimes with lutetium dotatate. Now, it's not 100% clear to me that these drugs are causing disease transformation. We see it sometimes in patients who have received neither of these therapies. But the possibility that this might happen opens up, room to consider maybe sequencing targeted drugs before the cytotoxic options. For example, starting with somatostatin analog, and then if the patient is able to tolerate a daily drug like cabozantinib, young, not too many comorbidities, maybe that's a good next step, and then save lutetium dotatate or capecitabine temozolomide for later lines. What are your thoughts on that?
I think a lot of sure boils down to patients' preference, to logistics, to comorbidities, and also concerns for side effects. There are some people who naturally have some concerns about the radioligand therapy, and let's say they may have very young children in the family, or may have a pregnant person in the household, so they may want to stay away from radioligand therapy for that reason. So there's just a lot of different moving parts that we need to consider. What I think we need to do is that we need to complete or try our best to enroll on sequencing trials. So we don't have a whole lot of them so far. So, for example, the Alliance trial that you mentioned, John, that is comparing CAPTEM with lutetium dotatate. There was a trial from Europe, the Oclarendum study that compared PRRT with sunitinib, showing that sunitinib was inferior to PRRT in terms of progression-free survival in patients with pancreatic NETs. There are other ongoing trials like the COMPOSE trial looking at a different type of a lutetium radioligand therapy compared to either chemotherapy or everolimus. So I think as more and more of these trials read out, the better equipped we will be to counsel our patients on what to do next. Maybe I'll go ahead and ask you, John. So, do you have any sort of clinical pearls for patient or for providers taking care of patients with the GEP-NETs? Anything that you would want listeners to walk away with?
So let me focus on metastatic small bowel NETs because those are the most common. So if we think about a typical treatment sequence, patient comes in with with primary small bowel NET, perhaps mesenteric disease, liver metastases. Very often they'll have flushing, diarrhea, and elevated urine 5-HIEA, in other words, carcinoid syndrome. In almost all cases, we'll start them on a somatostatin analog. We'll talk to our surgeons if it looks like they may be a candidate for debulking surgery, meaning removal of a large number of liver metastases or resection of primary tumor along with mesenteric disease. And then when they progress, the main two considerations are either liver-directed therapy or lutetium dotatate, with everolimus traditionally being another option, perhaps less preferred in most cases. And now in the future, if cabozantinib is approved, that will be added to the mix of options, typically after progression on, at the very least, lutetium dotatate. The clinical pearl about lutetium dotatate, which we've reported on, and you have as well, is that patients with peritoneal carcinomatosis are at risk of bowel obstruction. So that's patients with high burden peritoneal disease, we consider a contraindication to lutetium dotatate. And also sometimes very large tumors in the root of the mesentery that are causing vascular obstruction, that can lead to problems as well with lutetium dotatate. So that would be my clinical pearls about small bowel NETs.
That's actually a really important pearl, and I have actually seen in some patients who have extensive bone metastases or like a retrobulbar or orbital metastases. I've seen some patients present with slightly increased or sometimes significantly increased pain from those metastatic sites, and I have found that giving steroids for a few days, maybe dexamethasone for 5 or 10 days, can actually alleviate some of that pain. So I think it's just something to keep in mind if someone presents with pain after PRRT. We have seen that patients with fairly extensive hepatic, bone metastases, and even patients with mildly impaired kidney function can be safely and effectively treated with lutein. So I just encourage providers to just keep that in mind, that these patients can oftentimes be helped very significantly with this. The other pearl I just wanted to throw out there is that a lot of patients who get referred to my clinic, at least with the presumed diagnosis of refractory carcinoid syndrome, may actually have a complication of the treatment, such as steatorrhea or pancreatic exocrine insufficiency from somatostatin analog therapy, or even bile acid diarrhea from prior small bowel resection. Just keep in mind that not all diarrhea in someone with a neuroendocrine tumor is carcinoid syndrome. Yeah, so I think we've covered a lot of ground in the last 30 minutes or so. I would just encourage those who take care of patients with neuroendocrine tumors to consult with the available guidelines out there. We have relatively recently published ASCO guidelines on systemic therapy, forthcoming ASCO guidelines on management of symptoms in neuroendocrine tumors. We have the NCCN guidelines, which you're probably familiar with already, but the guidelines that you may or may not be as familiar with would be the guidelines of the North American Neuroendocrine Tumor Society, or NANETS. We have some guidelines there. The European Neuroendocrine Tumor Society, or ENETS, has guidelines, and then ESMO has guidelines as well on NETs. So there is a good number of guidelines out there, but they can sometimes be a little challenging to find.
I agree. The neuroendocrine tumors are probably harder to manage based on guidelines than most, because they're so diverse, so heterogeneous, and the treatment is so personalized. So you can look at the guidelines, but it does, I think, take a lot of experience to really start to understand how these cancers behave. And so that's the challenge, but also the fun of managing patients with neuroendocrine tumors.
Very true. And we have a growing number of what I would consider neuroendocrine tumor centers around the U.S., so certainly something to consider. A referral to a specialized center for NET management is often very appropriate.
Absolutely. Well, thank you very much. It was a pleasure.
Likewise. Thank you.
Thank you, Drs. Halfdanarson and Strosberg, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, clinical focus, expert insights on new advances in the treatment of GEP-NETs, please click the link in the show notes. And be sure to check back regularly for more episodes on important oncology topics.